Okay, so for liver, I provided here a picture that kind of shows the system more or less. So you guys see here, you have your liver, you have the two, uh, like all the things that provide blood for it. So you have the artery that's providing it with oxygen, rich blood, as it's going from the heart all the way to the body and the liver. You have also the hepatic portal vein, which is providing nutrient-rich blood. So that's going to be blood that kind of from the GI kind of tract. It'll makes its way through the portal vein and makes it to the liver. And you also see this connection between the liver as well as the rest of the GI tract with the bile duct. And here, I think this is also the gallbladder. So the liver is involved in, as you guys recall, uh, the production of bile. It's involved in the breakdown, or the utilization of bilirubin to use in bile, which helps to break down fats. The liver also helps to detoxify things. It makes things less active, so it deactivates drugs or substances that you ingest. So it's going to be one of the things that helps with drug metabolism. So in general, when someone's taking a drug, it's either going to be metabolized or it's going to be worked on mainly by the liver or the kidneys. And the liver, one of its biggest jobs to is going to be to make a lot of things deactivated, and it usually does this. It manages to do this by making things more water soluble. And by making things more water soluble, you're able to then pee it out, um, kind of working. You see how it works with the kidneys in that way. The liver helps to make things easier for the kidneys to then get rid of. So they work together in that sense. So here, again, as always, I denote yellow stuff as being important for the class, and this blue-green kind of thing as being additional information that you don't really need to know. You don't need to know, but it's there for context. So here, some of the stuff that they go over in lecture that you don't really need to know. This is just a fun fact. This is a fun fact. Don't worry about it. The biliary system, you don't have to know any specifics, but just know that the liver does make bile. Oh, sorry, the liver, yes. Well, the liver makes bile through different, it takes cholesterol, it takes the bilirubin and stuff, and it kind of goes through this route, but you don't really have to have that memorized. Just know the liver makes bile, the bile gets stored in the gallbladder. The specific ducts and stuff, don't worry too much about them. You're not really going to be asked about anatomy. It's going to be mostly about assessment and interventions. The main thing you need to know about bile is that it is used for fat digestion. And it has bilirubin, and bilirubin is going to be one of the main labs that we will be looking at for this section here. Here again, more information that you don't need to memorize at all, but it's just there for context. If you're someone that really needs to know this kind of stuff, a gallbladder then, concentrates the bile and whatnot. I think I should have another picture somewhere over here that kind of shows the exact pathway. If I don't, I will post it in a second. So here is a really good picture I like. So this right here, you can kind of see, kind of going back and referencing both of these pictures, you have this bile duct, and this bile duct is this whole thing here. It makes its way to the GI tract eventually. But here we have what's called the common hepatic duct. So that's what's going to be coming straight out of the liver, as you can see from the word hepatic. And this common hepatic duct is going to make its way into, this is called the common bile duct. So if you've had someone with gallstones, you might have seen this abbreviated as CBD. That is your common bile duct. That is essentially, if you can kind of see from this picture, It is the part of the duct that is connected to everything. It is connected to the hepatic duct, which connects to the liver, the cystic duct, which is connected to the gallbladder, and the pancreatic duct, which is connected to the pancreas. So it is because of this connection right here that you have a lot of issues with the gallstones that we learned in last semester, where it can cause liver impairment and pancreatic impairment, and cause some of those labs to be elevated or abnormal. So that's where that kind of comes from. So if you have stones here, they make their way through. You can have them get stuck in the cystic duct. You can have them get stuck in the common bile duct. Depending on where it is getting stuck in the common bile duct, you might cause some issues with liver or pancreas. So that's kind of where that connection comes from. And here you have stuff about the portal system that, again, you don't need to know at all. I'm not even going to go over it, but if you are someone that needs context for these things, that's the context for you. But again, anything that's in blue or blue-green, you don't have to know. What you do need to know is portal hypertension. So what is portal hypertension? So similar idea to other types of hypertension and things like that. You have this hepatic portal vein that provides nutrient-rich blood to the liver. So it's one of the things that the liver needs in order to function properly. If you recall, your liver has that thing called the first pass. So the liver is one of the things that anything you ingest um, through the GI tract is going to get worked on by the liver. And one of the ways to avoid that is usually through other kind of getting medication or ingesting th or kind of getting things into the body through other ways to avoid the first pass phenomenon. But it is that vein that gets to the liver. And if this vein has too much going on, imagine like a traffic jam. You have this highway that only has two lanes and it's completely jammed and traffic is slow. So that's where that you have that hypertension happen because there's just too much going on. The pressure is too high in this portal vein, and that's going to lead to issues as well because that means the liver is now lacking one of its sources of blood and one of the things that it acts upon. Does that make sense so far? Yeah. So other things that can be affected by issues with portal hypertension. We know liver impairment, which I just explained why that makes sense because the liver is not getting what it needs. Portal hypertension, so not just with the gallbladder, not just with the pancreas, the spleen is also involved in functions of the like in this whole system and in functions of the liver because if you guys recall with the leukemia that we talked about, with leukemia, you can have liver impairment and splenomegaly, hepatomegaly and splenomegaly, because they're both involved in some way with the compensation of lacking red blood cells. So they both kind of act and kind of compensate that way. And also, your spleen is one of the main organs that is actually going to be helping to break down old red blood cells and provide that bilirubin that is a waste product that your liver then uses to create to make bile. So the spleen is involved in some way with this whole system in that way. So when you have portal hypertension, not only can you have liver impairment, you can also have splenomegaly, which, if you recall from the leukemia, I mentioned that just kind of start thinking of splenomegaly as having the potential for pancytopenia, even outside of the realm of leukemia, which we kind of already expect pancytopenia in leukemia. Splenomegaly in general can lead to pancytopenia by itself. And then this is another way that splenomegaly can happen. So here I wrote down like the explanation of why this occurs. The spleen becomes overactive because it's bigger. So it's bigger, it's able to take in more things, which means it's also acting on more things, higher surface area. It's breaking more things down than it should, which can lead to pancytopenia that way. Having splenomegaly doesn't automatically mean you're going to have pancytopenia, but it increases the risk, and the worse it is, the more likely it is for you to then have issues with low platelets, low white blood cells, low red blood cells. Okay. So next up is jaundice. So we all know jaundice. We know it's something that we can assess. And it's caused by the buildup of bilirubin. Bilirubin is a yellowish pigment. One of the things of note is that when jaundice is a slow process, it usually will occur first in the eyes, and that's called scleral icterus. So you will see when someone has jaundice, you don't just see it in the skin, you can see it also in the sclera, so that's the white parts of the eyes. You can see it in their mucous membrane. So if they open their mouth, it might be yellow inside there. So this is typically the order it occurs. So in the eyes, then mucous membranes, and then the skin. That's typically the progression that you see with somebody having liver impairment and jaundice. Eyes, mucous membrane, skin. There are some conditions, or there is a difference between different types of bilirubin that can be measured in the blood. So we know, as I'll mention later, that we learned in class, conjugated versus unconjugated, and they can have a difference in how the jaundice occurs. That we'll talk more about later, but this is just kind of the general idea. And you don't have to memorize it, but it's just kind of something for you to think about when you're assessing a patient with liver impairment. You can assess not just the skin, but assess the sclera of the eyes, so the white part of the eyes and the inside of their mouth, mucous membranes and stuff like that, to see if they are jaundiced. And then you might be able to see progression there. So we talked about the dual blood supply. Something that was mentioned was the Kupffer cells, which help to clean the blood. So that's the detoxification. You don't have to memorize anything about the Kupffer cells, really. Just know that they exist. And then here, the portal vein, we kind gives you like a common pressure that you also don't really, I don't believe, have to memorize, but it's here for you if you need it. Any questions on the very basics of liver? We will go over assessments and interventions and labs later, but this is just like the basics. And I know I'm kind of going over pretty quickly, but I'm just trying to get through both. And that's why we are recording this. So if you need to go back and re-listen, then it's there. But again, for the most part, your priority in this course in nursing school is going to be assessment, interventions, and kind of understanding some of the labs and stuff like that. The patho is not really as important. Any questions? Okay, sounds good. So here it's kind of going back to what I mentioned. There is the basics of the spleen. So I mentioned the spleen helps to filter out old or damaged red blood cells, white blood cells, and platelets. So from there, when someone has splenomegaly, you have that risk of them having pancytopenia. But again, it's not necessary. And again, there's some other extra stuff that you don't need to know. Um, but the main thing that I just want you guys to remember is this is how the spleen functions. This is what it can lead to. And portal hypertension alongside leukemia, like we learned last week, are ways that the spleen can become enlarged. Just two of the ways it can become enlarged. Okay. So now I'm going to talk about more application stuff, and this is where you guys come in. So liver functions. So some of the things the liver does is, as we learned in like the first few semesters, the liver stores glycogen, um, which is what is glycogen? And what do you think happens when the liver is impaired, knowing that the liver stores glycogen? Yes, so when the liver becomes impaired, what do you think can happen knowing that the liver stores glycogen? So if the liver's impaired, there's impairment in the storage of glycogen. So what do you think that could lead to? Yeah. Yeah, so like hypo or hyperglycemia, yeah. So like a dysregulation of glucose in general. Because if you're having issues storing it, that can mean that one, you're having a harder time taking excess glucose and turning it into glycogen to be stored, or it can mean you don't have as much glycogen. So when you're low on glucose, there's nothing to tap into to increase your sugar levels. So glucose dysregulation are things for you to think about with the liver. It could be both, yes, for that purpose. So difficulty accessing stored glucose when hypoglycemic, aka it's going to lead to hyperglycemia, or it could be difficulty storing glucose when hyperglycemic, which then can lead to did I mention that? Other way around, sorry. Difficulty storing glucose. I switched this up when hyper. Oh, no, no, that's right. Sorry. When accessing stored glucose when hypoglycemic, which then leads to hyperglycemia because you can't put it away, and then difficulty storing glucose when hyperglycemic, which I guess kind of can lead to the same thing. Let me just make sure I'm not thinking weird. Accessing stored glucose leads to no other way around. Accessing stored glucose when hypoglycemic, which is worse hyperglycemia. Sorry, that makes more sense. Worsened hypoglycemia, like basically unable to fix hypoglycemia. Yeah, and then this one you're not storing glucose, so worsened hyperglycemia. That makes more sense. Yeah, does that make sense? Either way, essentially the idea is you're having a harder time either getting glucose or getting rid of glucose. So whatever you're at, it's harder for you to get out of that state. Okay? Your liver also has stores of fat-soluble vitamins, which is your A, D, E, and K. For the most part, I just want you guys to think about the liver and its effects on vitamin K. So what happens when you're deficient in vitamin K? Yeah. So risk of bleeding. Yes. So remember Coumadin? Remember Coumadin? That was an anticoagulant. The way to reverse that effect is with vitamin K because vitamin K is something that the body uses to promote clotting factors. So what I want you guys to really understand with this one is the glucose dysregulation. So when your liver's impaired, your glucose can be impaired. When your liver's impaired, you have a higher risk of bleeding. So clotting factors is a big thing with liver as well. So when someone has liver impairment, they're at risk of bleeding. When someone has liver impairment, they're at risk of their blood sugars kind of being weird. And that kind of also goes with the potential for, if you kind of go back, because you have this system, this portal system, and this is like the bile duct, but you have like this whole portal system that involves the liver, it involves the pancreas and whatnot. You also have that connection there where impairments of those systems can lead to impairments of the other systems. And we know pancreas directly is involved with the making of insulin and glucagon. So that's kind of where that relationship also lies. There is also impairment in storage of iron and copper, but for now, don't really worry so much about it. Though iron, we know iron is like when you're lacking iron, what kind of happens? Or rather, what kind of deficiency? Yeah, anemia. So the iron deficiency anemia, which kind of also goes with it kind of also makes that deficiency kind of makes that risk of bleeding thing even worse. They're already anemic and they're at risk of bleeding. So these are the things you really want to think about. And in general, a lot of the liver stuff that we'll go over kind of has to do with bleeding. Um, and I'm kind of hinting at like the varico yeah, like the esophageal varices um kind of thing. Okay. Kind of like I mentioned here, cleansing and filtering. You're inactivating substances the liver does to make them more water soluble. And why did I say being more water soluble is effective? Excretion, yeah. So why is turning things more water soluble good for getting rid of things? Yeah. So kidneys can have an easier time getting rid of them through urine. So that's not like the most like you're not going to get directly tested on this kind of stuff, but it's good to think about. Kind of like a pharmacology thing where, your liver and your kidneys are going to be the main metabolizers of medication. So just kind of things to think about, like certain antibiotics affect liver more than kidneys, but usually it's the kidneys, but like certain medications will affect the liver more, certain medications will affect the kidneys more. Like for example, we know NSAIDs affect the kidneys more, Tylenol affects the liver more. So that's kind of the general idea. When in doubt, it's going to affect one of those two organs because they're both involved in drug metabolization and things like that. Okay. So here, kind of like I mentioned before, drugs and hormones are inactivated by the liver, but this also includes insulin. So we mentioned there's glucose dysregulation, but similar in this vein, if the liver is impaired, you have a higher risk of hypoglycemia, like we mentioned before, but you do also kind of have that other risk of the hyperglycemia if you are hyperglycemic already. But for the most part, the main issue is typically going to be um that's really inactivating the liver including insulin. Yeah. So you're unable to you're having a difficult time inactivating the insulin, so it stays in your body. So if insulin stays in your body for too much, it's going to drop down your blood sugar. So you have a lot of funky things happening with blood sugar with this. Again, focus mostly on the stuff that's in yellow. The other stuff is nice to know, but it's not a need to know. Okay. So now albumin. So when albumin is low, what can that lead to? So low albumin, which leads to what? Fluid imbalances, yeah. Ascites edema, yeah. So you have a lot of like edema, ascites. Yes. So a lot of fluid imbalances, electrolyte imbalances going on here. But we know that ascites is like one is like very associated with liver. And I will also mention here, this is probably the most important stuff when it comes to this. One extra thing to think about with albumin, um, that you maybe probably learned during farm, but maybe don't remember, is just that the albumin is one of the things the body uses to inactivate drugs. So you also have reduced inactivation of drugs. Your albumin is something that attaches to a lot of things in order to inactivate them. So if you're having a hard time making albumin, you're also having a hard time metabolizing things. We all know that alcohol and the liver kind of go together. So it's kind of there. And right here is the protein metabolism. So one of the big things with people with liver is that they have a risk of having high ammonia levels. Usually when their levels of ammonia are high, what do you kind of expect to see from them? Alter level of consciousness, yes. So that's called hepatic meaning relating to liver, encephalopathy meaning kind of encephalopathy, encephalo means like head, pathy means like disorder of. So essentially this is saying hepatic liver related confusion. Okay. And here's the general breakdown of things. So you have protein, you consume something that has protein, it's going to be broken down into amino acids. That gets broken down into ammonia, and the liver is there to break down ammonia into urea nitrogen. When it's unable to do that because the liver is impaired, it will stay as ammonia and it will populate your blood. And ammonia is neurotoxic, meaning it affects how your brain functions, which is where that altered level of consciousness comes from. Low protein or protein restriction. I mean, that's something you can do. That is something you can do, protein restriction, to help prevent the buildup of ammonia, but there is other things you can do for it that we'll talk about in a little bit. But if you notice here, kind of just signaling back to how the liver and the kidney play with each other, urea nitrogen. If you remember BUN, oh, oops, that's in, okay, open something by accident. If you remember BUN is blood urea nitrogen. So you see that whole system. Your liver breaks down ammonia, and then your kidneys get rid of urea nitrogen in the urine. So you can see at play how the liver and the kidney work with each other to eliminate things from the body. I don't believe you have to hard memorize the values, but just in case, I did write it down. And once we have all the numbers together, you'll kind of see a pattern where a lot of these go off the number 45. So most of these numbers should be under 45 and a lot of them should be above 45. We'll talk more about it when we get there. You didn't mention it? All right, perfect. Then probably don't worry about it. I don't remember having to memorize it. So that's just kind of how that goes. And then here we have your albumin. Your normal levels of albumin is the same as your normal levels of potassium. We mentioned this already. So third spacing. Oh, okay. Then yeah, you should then know this one then. Then know your albumin level. It's the same as your potassium level. And we already talked about this. Clotting factors when low, increased risk of bleeding. Sorry, I am going pretty fast right now, but hopefully the pace is not too fast. And again, this shouldn't be your first exposure to the material. So you guys should have some idea of it, but yeah. And we already talked about this. If jaundice is not able to be removed, you have jaundice because bilirubin is like a yellow pigment. So that ends up building up in the blood and giving you kind of a yellowish appearance. And this thing right here is not mandatory to know right now, but it's there for extra information. So now I'm going to give you guys like a little summary, liver summary right here. So what are the main things you really have to know is when impaired, you can expect glucose dysregulation, especially hypoglycemia. We can expect bleeding risk due to reduction in clotting factors and vitamin K storage. We can expect third spacing. So we'll have like edema, general peripheral edema, and typically you will have peripheral edema before you get to the ascites. What else? We have jaundice, and we kind of have that whole, it goes eyes. Typically, like if it's a slow progression, it goes mucous membranes, and then skin. And then what else did I forget here? Electrolyte imbalances. Oh yeah, altered level of consciousness. Let me see if there's anything else I forgot. We talked about reduced let's say increased risk of toxicity, um, impaired inactivation of drugs. So this should be like a pretty good overview here of what to expect when the liver is impaired. Any questions on this so far? All right, so now we're gonna go through the labs. And for the LFTs, malabsorption, malnutrition, that should be true as well. because it has that. Yes, I'll include that as well. Nutrition. Yeah, because the liver does kind of work with that nutrient-rich blood and stuff. So there is some of that as well. Okay, but that should be like the main thing. Okay, so what are the no, what are the names of the LFTs? We'll kind of just work with that first, just with the name. So you have AST, ALT, and last one, and ALP. You do have GGT, but most people, we don't really have to know it for now. And then bilirubin's right here. So, you said, Anne mentioned, or someone mentioned mainly ALT. Yeah. So ALT is liver specific, the most liver specific of these. But it's worth noting, and I'll tell you like a little secret with all of these later. ALP, when ALP is elevated, what can it be a sign of? And this is something kind of went over during 220 bile. Yeah, usually it means there's usually a blockage. Yeah, usually indicative of, yes, bile obstruction. Okay. And I will write down the numbers and you'll kind of see how there's like a pattern forming here whenever I get to it. One second. So with ALT, this is your normal. With AST, this is your normal. ALP, this is your normal right here. So if you kind of go back to the ammonia, and I'll bring ammonia closer up so we can kind of see that comparison. You can kind of see the number 35 or 45 is pretty, is kind of like a benchmark for both. So for ALT and AST, under 35, it should be good. For ALP and ammonia, you have the number kind of 45 as a benchmark. Ammonia should be under 45. ALP should be above 45. You can kind of see that pattern there. That should hopefully make it a little easier to remember. However, I don't believe you have to honestly memorize it, but that's a way for you to remember it. Um, and then kind of when we go a little bit lower on cirrhosis, when it comes to these labs, they're not really function tests, even though that's kind of how we're referring it to. These are essentially enzymes and like enzymes that your liver makes. So when these numbers are, when the liver is impaired, the idea is essentially that the liver is kind of inflamed and releasing more enzymes than it normally would because of the impairment and causing inflammation. So it leaks more enzymes out, and that gets calculated in the blood. But when the liver is so impaired, you can actually have these numbers come out normal or even low. The idea being that when there is so much liver damage, your liver is no longer even able to make these enzymes. So there's nothing to leak out into the blood. Does that make sense? Yes. End-stage liver disease, hardcore severe cirrhosis, these numbers can be normal or low because they don't directly represent how the liver is functioning. They are just a sign of how much liver enzymes have leaked into the blood. And if the liver is severely impaired, it's not even making the enzymes very well to begin with. Make sense? So typically they're high because the liver is inflamed and we're still kind of earlier stage. Later on, the liver is not even able to squeeze anything out. It's done. It's just done. And therefore, there's nothing to leak into the blood. All right. That's just like a little fun fact. Mention ammonia and how that can cause confusion and stuff. And I'm going to quickly go over the idea of conjugated versus unconjugated bilirubin. If I recall, you don't need to know the numbers. You don't need to know the numbers. The way I remember bilirubin is for the most part, like creatinine should be under like 1.1 or 1.3. Bilirubin is kind of the same idea, should be under like 1.2, 1.3, 1.1. So they're on similar kind of levels that way. And I always remember them together just because liver and kidneys are like best friends. So that's how I remember it. But again, I definitely don't think you need to know the numbers for conjugated and unconjugated. I don't recall having to know that at all. If you do need to know your bilirubin numbers, then you just have to know this one. Okay. So the next thing to know about these is what does it mean to be conjugated and not conjugated? So here as it's written, when something is non-conjugated, that means it has yet to be acted upon by the liver. So non-conjugated, think of it like not acted upon. Okay? Unconjugated, not acted upon. So that means the liver didn't even get to it. Why might that be the case? It's because the liver itself is impaired. So when you have high amounts of unconjugated, it means the liver couldn't even get to it because the liver couldn't even start the job because it's so impaired. It's late to the job. It couldn't even make it there. It does help, yes. It will help to know if this is a liver versus a, yes, it does. There is some more nuance to it, of course, but kind of you're looking at your ALP and your how the conjugation of your bilirubin and also through like CT scans and stuff like that is kind of how you rule that out. But that is the general idea, yes. So conjugated, the bilirubin has been acted upon by the liver, but it's not making its way to the gallbladder because there's obstruction. Because that's the next step. Once the bilirubin has been conjugated, it then goes to become bile. But if there's obstruction on that whole bile system, it can't. And like I said, there is more nuance to it, but you don't have to know the nuance. There is a little bit of extra nuance in terms of how the jaundice then builds up. Can we have a good liver, have sickle cell disease, and so unconjugated bilirubin high? That is also possible, especially if it's having a crisis because it's all acute. And something and kind of where I'm mentioning um although I will say this, and part of where I mentioned like the nuance to it is that you will have the liver actually kind of like kidneys. Did we go over kidneys yet? Not yet, right? No, kidneys later. But your liver does its best to function on bilirubin. It's kind of not like the hardest task for the liver to do. So it usually will act upon the bilirubin even when it's impaired, unless it's very highly impaired. That's some of the nuance that, again, you don't have to know, don't have to memorize, don't have to worry about it. But it's here if you need to know, if you feel like you need to know, or maybe on the NCLEX, probably not. NCLEX is not this deep into patho, but that's the general kind of idea with that. Okay. And then here it's just kind of reminders of your PT, INR, PTT, because kind of like I mentioned before, it has an effect on your clotting factors if the liver is not working properly. So like I said, you can have a CT ultrasound to check for abnormalities and the flow of blood, obstruction, all of that stuff is there. And then a liver biopsy in case you're kind of worried about cancer or just kind of seeing how the liver's doing, cirrhosis and stuff. Any questions so far? Because I know we covered a whole bunch of stuff. Don't worry too much about the specifics and nuance on the bilirubin types. The main thing that just kind of keep it simple. So this would be the simplest you have to kind of think about. This is as far as you really have to think about. And then here we're gonna fatty liver. Um, Kind of like I mentioned up above briefly, your liver is in charge of creating cholesterol. So your body makes its own cholesterol. And when um, your liver's impaired, it's also going to have a harder time kind of dealing with all that. And because it's in charge of both storing cholesterol and creating cholesterol. So in this scenario, when you have fatty liver disease, you can have it due to alcohol damage. You can have it due to just obesity and lots of fats happening. So your liver has a hard time keeping it all stored, or your liver might have a hard time um, kind of getting it out. So different things like that. But the main idea here is just that you have fat built around the liver, and that causes inflammation. So a lot of the time, the way to hopefully try to fix it is better diet and then less alcohol and smoking, which is something you'd want to do anyways, and then just a change in diet. So it kind of speaks for itself. Fatty liver disease, you want to fix your diet. Makes sense. For gallstones, I don't think so. Gallstones is usually more acute. Gallstones are usually acute. So a gallstone is not something that's chronically happening, or at least when I say gallstones, I mean gallstone obstruction. People can have gallstones in their gallbladder and be completely benign because they're in the gallbladder. They're not getting stuck anywhere. So, but like I mentioned, that's acute. That's like an acute thing. This is more like a chronic long-term thing. As you can see here, it's reversible until it gets to the point that it causes so much damage that it's now irreversible. But that is the general idea here. That's really all you need to know about fatty liver is just it causes liver damage. You can apply everything above to this because eventually this leads to cirrhosis. So it's all applicable within the same idea, but because it's fatty liver disease, think about the change in diet and how it can be caused by hyperlipidemia and stuff like that. Okay. Lastly, here we have cirrhosis. So this is going to be the main key thing is that it's irreversible. And here are some of the causes for it. So gallbladder disease here would be like a chronic cholecystitis, as opposed to gallstones, which is an acute thing. Because your liver, metabolizes alcohol, too much alcohol over time, damage. It metabolizes drugs and toxins. So if you keep abusing Tylenol or something or other medications that um, cause the liver to metabolize them over time, damage. Fatty liver, like we talked about, can cause long-term damage. And then hepatitis, the different types of hepatitis that I'm gonna immediately just tell you out front. The focus for this exam is not going to be as much on hepatitis, and don't spend too much time hardcore memorizing the different types of hepatitis. It Yeah, it's not going to be the focus. Okay. I do have a picture right here of what someone with long-term kidney disease would look like. So this is kind of some of the things. You can kind of see edema. You can see ascites. So they have this buildup of fluid because of lack of albumin, like we mentioned. They might be a little bit yellow. I guess it's not really pictured here. But that's some of the things that you'll see. We talked about almost all of these, so I will just copy paste here from what I have because we already kind of talked about it in depth. One of the only things we didn't really talk about too in depth was this thing called asterixis, which is the hand flapping. All you really have to know is high ammonia levels, hand flapping. The only other thing we didn't really mention is this right here, the hepatomegaly. You can have the enlarged liver due to inflammation, and it might be palpable, and it might be causing pain or tenderness. Everything else we talked about, and you guys kind of already know about it. Some of the early signs is pretty vague, so we're just gonna post it here. You have fatigue, because remember it can cause iron deficiency anemia, so that can lead to fatigue. Changes in your weight because of fluid buildup. Liver is involved in GI, so things like nausea, vomiting, lack of appetite. We mentioned abdominal pain here with the hepatomegaly, and then pruritus is like itchiness. I believe that itchiness is due to kind of things building up in your blood, and I think the bilirubin buildup can cause you to be itchy as well. We talked about all these labs already, so they're already listed. And the main important ones I have highlighted, really. Albumin's important, but it's something, I guess I'll highlight it too. But it's something you can probably, when it's starting to cause problems actively, you'll see it physically. One of the things that's listed here is BUN and creatinine. You see this because there's hepatorenal syndrome. Remember how much I've been talking about of how the kidneys and the liver work together? When you have impairment in one and it's kind of getting more worsened, it's more severe, it starts to affect the other one. So there is that connection between another connection between the liver and the kidneys here. So it's something to think about as well, is how that relationship is and like if it's affecting one or the other. Okay. Again, more of the same thing, the ultrasound, the biopsy, and again, a little bit extra information that you can logic out is just kind of position the patient. You need informed consent for any procedure, invasive procedure. You can give them some sedation before. Probably the main thing when it comes to the liver biopsy is that as opposed to a lot of things, this one they're actually going to lie on their right side as opposed to their usually for like most other things it's always like, oh, put them on the left side. This is like the exception. The liver specifically, you put them down on the side of the liver because you want to keep putting pressure there. Because if you're like irritating the liver, maybe it causes increased risk of bleeding because you know how the liver is involved with the clotting factors and stuff. And then we have some of the complications. We have the portal hypertension um, that we kind of talked about. We're going to kind of go into more detail down here, but we mentioned splenomegaly. This is something I didn't talk about too much, but I think I have it listed somewhere over here. Yeah, I do. So we'll talk more about that as we get down. Esophageal varices, which I kind of hinted at in the beginning, and the hepatic encephalopathy that we talked about. Oh, and also the hepatorenal that we talked about. So out of here, the only things we haven't really gone into detail is the bacterial peritonitis, esophageal varices, and the portal hypertension. Any questions so far? Ah, okay. Yeah, it's going to be recorded, Anne, so don't worry about it. And in the recording as well, or if not, I remember I gave you guys a link to the previous session, so you can still have something. if you need it. Okie dokie. Portal hypertension. The idea is now, yeah, the idea is now that you have all this backing up of blood, you're going to have increased pressure in that system. But really, the main thing that you want to think about for this condition are going to be the complications. So the complications of your portal hypertension is going to be some of these things. So because that portal system is involved with the spleen, like we mentioned, splenomegaly, increase spleen size. Hepatorenal disease, kind of like we mentioned, if the liver is impaired, the kidneys can follow. Infection, which we'll talk about in a little bit, and then esophageal varices. So these has to do with like a bleeding risk. What esophageal varices means is that essentially, because again, your liver is involved with the GI tract, the esophagus is part of the GI tract. In order to kind of improve the blood flow, it creates new circulation, and some of that new circulation is usually very fragile. So these varices on is that's created on the esophagus are they're like enlarged. They are engorged, kind of looking a little engorged, enlarged, and they're very prone to rupturing, which also then means that you have high risk of bleeding. And that's really going to be your focus here. So again, with liver, your focus is a lot on um, bleeding, glucose dysregulation, fluid changes. So that's a big one here. The assessment is going to be something that you can honestly apply to every patient with liver impairment, especially if they already come with ascites. Your big thing is going to be abdominal girth and weight. So you can see the progression of the ascites. The weight, progression of kind of fluid imbalance. So they kind of go together. Okay, what else can I mention about this? Uh, um, Another thing to do is like the bleeding. So if someone is at risk of like bleeding out, um, did you guys go over like the different types of signs for bleeding? Okay. What about internal bleeding? Okay, not yet. Okay. So in this case, I'm kind of referring to what's called Gray Turner sign and Gray Turner's and oh, you did go over that. Yeah. That's a sign of like internal bleeding. So that's another thing you should watch out for. If you suspect bleeding, and you can have like GI bleed, not just like appearance wise, but it might also show up as increased like abdominal girth. Yeah, colons and well, Turner's and colon sign. Yeah. So the way to kind of remember it is this is kind of looking like a C. You can kind of see that's kind of like a C. So C for colons, and then gray Turners on the side. And the way I remember it is you got to turn them to see it because it's on their side. So Turner sign because it's the one you have to turn them for. Here's another sign, and then colon signs kind of like around the belly button. So doing like a little C on the belly button. That's kind of how I recall. That's how I remember it. And again, you can kind of see this as well with the abdominal girth. Okay. You do have something called tips. The idea of tips is essentially kind of like I mentioned that portal vein is kind of like a congested highway. the idea of a TIPS is it's a temporary fix. It's like a shunt. So it's essentially like almost like building a new road. So you have this really congested highway, only has 2 lanes. Imagine if we were to create a third lane. That third lane would allow traffic to move by quicker. And then this kind of helps fix that traffic and reduces the portal hypertension. But again, it's like a temporary fix. You still kind of need to work on other things like working on whatever is causing the liver impairment to kind of do it because it's like a temporary thing. But it does kind of help to alleviate that. So again, here's kind of what I wrote is it's like building a new road, building another lane in traffic to help things go by faster. And the main thing with that is of that if you are helping with the decreased portal hypertension, therefore you will see things such as decrease in the signs and symptoms that we talked about. So assessing your abdominal girth again is important here. Okay. Any questions so far? Because I know I am going very fast. Okay. So ascites, again, I keep kind of bringing it up. It's because of albumin, and um, you're gonna have to measure it to kind of see the progression. Ways to get rid of the ascites. You guys should have done like an iHuman where they kind of do this. They do what's called a paracentesis. Kind of similar idea to a thoracentesis where they're getting rid of fluid in the lungs. Instead of here, you're getting rid of fluids in the perineal area. Yeah, no worries. Yeah, just listen to the recording and you'll be okay. Diuretics can also help. So then now let's go talk about paracentesis. You're gonna have all the same stuff that you would expect from like an invasive thing. You need informed consent. You should take your vital signs and the weight before and after. As we saw in the iHuman case, that patient got a ton of fluid taken out all at once, so they were starting to have issues with their blood pressure. So that iHuman case can be a reminder for why you'd want to take the vital signs before. You poked at some place, so you want to apply pressure. And like I mentioned, yeah, you just want to apply pressure to the site. The reason for why they want to have an empty bladder is because the bladder, if it's full, can kind of get in the way. You might accidentally poke the bladder instead of like by accident, just because it's kind of bloated with pee. And then complications. Complications you can kind of expect pretty obvious stuff would be like in the iHuman case, hypovolemia, shock, bleeding, infection. Anything invasive, you can expect bleeding, infection to probably be there. And in this case, like we saw in the iHuman, the guy was hypovolemic because they lost a lot of fluid all at once. Okay. Here we have esophageal varices. So here you can see the varices. So again, that is like a new created circulatory. Your body to try to compensate creates new vessels, but these new vessels that it creates are very frail. So if they rupture, then they have a very high risk of bleeding out. And this is because it's esophagus. You can imagine that this is diagnosed with, the EGD, which is your upper GI diagnostic, as well as, signs of bleeding like them bleeding, like them bottoming out and having a change in their level of consciousness. So there is a difference between the treatment when they're when you're trying to prevent them from rupturing versus the difference when it is rupturing. So can you guys list some of the interventions for prevention or active bleeding? Just so we're trying to make it a little bit more interactive, although I know that I do gotta do this pretty fast. So I think this is pretty important here because there is a difference in your interventions and they're actually pretty opposite almost, kind of like your DVT. No worries. Yeah, you guys did just have your CPE. Kind of like your DVT, you have your interventions are basically almost opposites. Electric shaver to prevent. Well, not so much. This is more like to prevent the varices from bleeding out rather than just generic bleeding out. Electric shaver would help for like general prevention of bleeding out, but this is like referring to the varices in the esophagus. So if we want to prevent these from bursting, what might be effective to prevent the blood flow to these varices from being too much? BPO, MPO. That could help, I think, just to prevent. So Fidel, medication that constricts blood vessels. So here is kind of like where that differentiation kind of goes and how it's like kind of opposites. So when when you don't have active bleeding, if you were to constrict the blood vessels, it actually increases the pressure there, which makes these more likely to burst. So when someone's having active bleeding, that's when you want to constrict. For the same reason that when someone is having like bleeding, you want to put pressure. When they're actively bleeding, that's when you want to constrict. When you want to prevent it, the intervention's usually like propranolol, and I think he also mentioned nadolol. So these are to reduce the blood pressure and decrease pressure in the varices. So you want to actually have um, medication. You want to have this medication that's there to decrease the pressure so that it's not going to burst. But then when you are actively bleeding, that's when you want sandostatin, which is called octreotide, which helps to this constricts to reduce. It's kind of like constricting to help stop bleeding. You got okay. I'm actually just gonna. I think for today, I know that we're trying to be interactive, but I'm actually just gonna go through it just because I know you guys are probably pooped from the CPE, and I want to make sure we can get through everything. So I'll just kind of talk about. I'll just talk instead. I know they don't want me to do that, but we're just gonna do it. So, um, going back to prevention again, prevention is kind of preventing it from bursting. So preventing of heavy lifting preventing, maybe you can give them medications to prevent vomiting and coughing because that can lead to, you know, kind of stressing out that area, which can lead to them bleeding out. But when they're actively bleeding, again, we want to constrict, just like you would apply pressure to a wound or like a bleeding wound or like a cut or something to prevent the bleeding. That's when you want the constrictors. We have the ice water thing, which is again constriction, because remember, cold constricts. We have a balloon tamponade, which is again, you're placing something deep in there, and I think we kind of saw this over here, maybe with it's when I looked up esophageal varices right here. You can kind of see this balloon being placed here and then expanded. The idea is, again, you're providing pressure to, similar to an open wound, an open bleed, you're providing pressure to stop the bleeding. And that's pretty much it for that. We talked a lot about hepatic encephalopathy already. Um, Kind of like we mentioned, the diet should be kind of lower protein intake because of how protein gets broken down to ammonia. We talked about level of consciousness. We talked about the asterixis, and now we're going to talk about the medication. Now we'll just kind of copy paste and we'll talk about it. One of the main ones you're going to be seeing is lactulose. So this is normally like a sugar actually. Or it's actually, well, it's technically a sugar, but it's also a something that helps to get someone to poop, helps with constipation. And in this case, the lactulose is helping you excrete ammonia because that's actually where your ammonia gets excreted. Extra ammonia gets excreted through poop. So kind of similar to how kyaxylate helps to reduce potassium by pooping it out. Here, your ammonia is also pooped out. So that's kind of where that helps. You have these other medications. These are both antibiotics, neomycin and rifaximin. The idea is you kind of destroy or kind of impair your own natural flora, your gut flora, because by impairing your gut flora, you're also impairing protein breakdown. So the way these two work, it's not that there's an active infection, it's there to impair your own system. That way, that way, it's not breaking protein as well because you have your flora in your gut that helps to break things down. So if you're preventing it from breaking down protein, you're also preventing it from uh, making more ammonia that way. You have spontaneous bacterial peritonitis. So the idea is right here. You can have translocation because the liver is not acting on certain bacteria. Again, it's having to struggle with that first pass effect. So bacteria, drugs are not as um, inactivated as you would want them to be, so they can make their way through and kind of make it through and cause peritonitis. Because again, it's all part of that whole kind of GI tract involved in that whole system. So here, what I have written down here is just kind of typical things you can expect with peritonitis. If you're getting acidic fluid when you're doing a paracentesis, it will look cloudy and yellow, as opposed to more like a straw colored. So similar to, like what you would expect, um, the cloudy, like what you if you expect like infected urine, you see cloudy. If you see kind of infected spinal fluid, it's kind of cloudy as well. And what you can expect from a bacteria, you treat it with antibiotics. So any specifics you don't really have to hard focus on. It was just kind of like basics on peritonitis or basics on infection here and just kind of knowing that it happens because of liver impairment. Here we talked about almost everything here already. Bruising is a thing, more drug toxicity, malnourishment because you're having a hard time um, absorbing things. So these patients can get what's called a banana bag, and you might get a banana bag for alcoholics too. And a lot of people that have liver problems are also alcoholics, as you know, as you kind of can expect. So having some of these is important because they're going to be low on it, especially alcoholics. Alcoholics need thiamine to prevent uh, like the thiamine deficiency, which can lead to altered level of consciousness, psychosis. So the banana, that's what the banana bag is for. And I'm sure he showed you guys a picture of the banana bag. That is not what I meant. There we go. It is this little solution right here. And it's basically NS and it's got all this stuff in here and it's yellow. So that's why they call it a banana bag. Now here, it's going to be very short. We do have kind of the acute infection, hepatitis. Like I mentioned, it's not your focus for this test, really is not. I do have this chart, but for the most part, you really just have to kind of understand the very basic signs and symptoms, which you can expect because we talked about all this kind of stuff. It's an infection, so you can expect to see you can expect having like fever and fatigue, jaundice because it happens to be a something that affects the liver, so we can expect that. Dark urine, that's occurring because of bilirubin buildup, so your pee. Um, so you'll see dark urine with like the conjugated bilirubin. So things like your liver acts upon it and it's more water soluble, but the liver is not really having an easy time putting it into bile, so it just gets peed out, and that's why your urine is dark because of the bilirubin in the pee. The clay stools, similar to your gallstone, um, happening. Uh, uh, um, and what else? That's kind of it. That's the main symptoms you really should know. For the most part, these have you're gonna, hand hygiene. Some of these have vaccines. For the most part, hand hygiene is going to be your best thing. But again, it's not the focus. And I do have a way to remember mostly the transmission part of it. So hepatitis A for agua, which is water in Spanish. So it's usually transmitted through fecal oral, so contaminated food or water. B, I put as like blood because it is the hepatitis most likely to, it's like one of the ones that is transmitted mainly pretty much through blood, blood or bodily fluids. C, it can also be through blood and bodily fluids, but the thing to remember with C for cirrhosis or cancer, because this is the one that leads most likely to those, to liver cancer and liver cirrhosis. And then uh, hepatitis D will really only affect those that have hepatitis B. So D and B, I think of Dave and Buster's, D and B. And then E is like the oddball out. I don't really have anything to kind of think about with this one. But like I said, honestly, it's not your focus. You have a lot of topics on this exam, and this is not one of your biggest focus. So that's all of it for this. I will kind of go ahead and just start saving it to kind of give to you guys, and we will. If you guys have questions, please type them up right now, and I will answer them to the best of my abilities. Otherwise, we will just kind of quickly go through pancreas much as we can, as fast as we can. Probably by like 5:30, I will have to leave because I probably have to shower and get all my food and stuff ready to go to work. But yeah, if we don't finish pancreas, then again, you have that video from last rotation where I go pancreas, and hopefully that's good. That's good enough. Okay, so if there's no more questions, I will just shift over to pancreas. This one's a lot shorter actually, so that's good. So maybe we can actually do it. I'm holding out hope. And I'm sorry if the pace is too fast, but yeah, unfortunate circumstances. So right here, this is just again an overview of your pancreas. The main thing you have to really know, it is involved with insulin and glucagon. Yeah, like 1.5 speed for sure. Glucagon and insulin. We know that some of the things we're looking at are your lipase, your protease, your amylase, and bicarbonate. are going to be some of the things the pancreas also makes. So what is lipase? So lipase breaks down fats, breaks down fats. Protease breaks down protein. Amylase breaks down starches and carbs. So as you can see, that is your macros right there. So your pancreas is heavily involved in digestion and nutrition. So again, if you go back to this lecture, this part of this here, you see how it's all kind of connected in this kind of GI tract. So if you're having gallstone, like a gallstone obstruction, or you're having some liver impairment or something like that, it can have an effect on your nutrition and your pancreas potentially. So again, it's all, you see how it's all connected there. We talked about how liver can have glucose dysregulation. Pancreas is directly involved with insulin and glucagon, and they're all kind of interconnected. Your liver helps the kidneys get rid of stuff. So we see here how we saw there how there's the hepatorenal. We have the kidneys being affected and vice versa when there's impairment of the liver, and then vice versa when there's impairment of the kidneys, you can have impairment of the liver. Oops. The only other thing to see here is octreotide. If you recall, just right here, we talked about octreotide for esophageal varices. Octreotide can be used to work as a constrictor, and this is actually a natural hormone. Octreotide is. Sandostatin is the synthetic version of it, but octreotide is a natural hormone that your body makes, or maybe it's somatostatin, and octreotide's the man-made one. But the point is, this is something your pancreas actually makes. It can be used as a constrictor for the portal system, but it can also be used, or the body is also used as a way to inhibit the pancreatic hormones, which is why you'll see it again as something that helps to prevent some of these pancreatic issues. Okay. So again, this picture comes back because it's all kind of connected. The main thing to know about acute pancreatitis is that it's that inflammation, kind of like you have the, like I mentioned, the inflammation of the liver leads to the release of those liver enzymes. The inflammation of the pancreas leads to the release of your pancreatic enzymes, these that break down your macros, breaks down fats, proteins, and carbs. Well, it turns out your organs are made of fats, proteins, and stuff like that. So if you have a release, too much of a release of these enzymes, it leads to these enzymes digesting your own pancreas. So that's a problem. Your own pancreas is your pancreas is essentially eating itself in this scenario, which obviously we do not like. That is not good. But that's kind of going to be the main thing that's causing issues with the pancreatitis. It's going to be um, that auto digestion, auto meaning self, digestion meaning digestion, breakdown of. So here, what I have here is kind of basically what I mentioned. Here's possible causes of your acute pancreatitis. Gallstones. Gallstones. We see in the system here. If you have gallstones here, and one of them kind of makes it through the duct, makes it through the common bile duct, depending on where it is, it can have, especially here, it can have an impact on how these enzymes are being released through the pancreatic duct. Because the pancreatic duct here is where the pancreatic enzymes would go. So essentially, you have the bile and the pancreatic enzymes both make their way to the GI. I think the small intestine, or I think it goes into the small intestine, and then a little bit farther into the small intestine, it gets all reabsorbed, and then goes back into the liver to be for the first pass effect. So, but the point is they all work together, and if this part's obstructed, the pancreas enzymes are going to be backed up. And if they're backing up and there's nowhere for them to go, they get stuck in the pancreas, where um, you have an abnormal amount of it, which is going to lead to it starting to break down the pancreas. And hence why your pancreas has its own enzyme to stop stop its own enzymes, is in order to kind of help to prevent this from happening, and also to help prevent it from just kind of happening with normal digestion. Because at some point, those enzymes are going to be in the pancreas, and at some point, those enzymes are going to make it to the duct. It's just like a way for it to self-regulate itself. But in this scenario, um, yeah, in this scenario, what's happening is that it's backing up and it has nowhere to go, and it's too much, and it's causing, again, breakdown of its own organ. Other causes, and I think he has the acronym "Get Smashed," which I love, which is funny. But I just kind of summarized it into the main one. So alcohol. Again, you can cluster a lot of these because alcohol, liver, pancreas together. That whole system, we can kind of really associate that whole system with each other. Liver, pancreas, gallbladder. High triglycerides. Well, we talked about how fatty liver is, can be caused by poor diet and hyperlipidemia. It comes back again, pancreas. You see how they're all interconnected, and hopefully that makes things easier to kind of have memorized or kind of have understood. And these are some of the other possible causes, but they're not going to be as prominent as the other ones mentioned. And the other ones mentioned are a little bit easier to remember because, like I said, they kind of go with each other. Here are your manifestations. So when you have pancreatic pain, your pancreas is in your left upper quadrant. If you want to take a look. So right here, left, left upper quadrant. So when you're having issues with, and here you can even exactly see this is the common bile duct right here. This whole part right here, this part up to here, this is the hepatic duct, cystic duct, pancreatic duct that makes its way right here. And then all of this makes it to the small intestine. So you can kind of see how it's all connected again, just through anatomy. Um, since your pancreas is in the left upper quadrant, acute pancreatitis is going to cause pain to the left upper quadrant. Some information that could be important is that it can radiate to the back, and also that it can be worse when the patient is flat. As for the reason for why it can be worse when the patient is flat, I actually don't know at the top of my head. It's probably just due to positioning on maybe how it affects maybe the enzymes, maybe they're just kind of positioned in a weird way. I actually don't know the reason. I can look it up, but it's not important. And to avoid wasting time, we'll look it up later. Um, because this is like a GI kind of thing, like we kind of mentioned, this is all kind of involved in the GI. You can kind of cluster that with like nausea and vomiting. So your nausea and vomiting are here. This person is gonna need to be, MPO, not only because uh they're leaking too much, they're leaking too much pancreatic enzymes, which is painful. It's causing nausea, vomiting, so they can throw it all up. They have like their bowels are slower, hypoactive bowels. They have fatty stools. They're not going to tolerate anything by mouth, and eating things by mouth is going to make it worse. It's going to make the pancreas keep acting up. So in general, this is like a GI thing. It's going to lead to GI issues. So this person should be MPO, which um, I'm sure you guys have talked about. And one of the things that's going to bring this guy to the hospital is going to be the pain. But like he mentioned for the test, your priority is going to be focused on something else, which I will hopefully explain in a way that makes it make sense for why breathing and airway breathing is like a concern, mostly breathing. because again, it is your pancreas. Your pancreas is involved in insulin. You can have this transient hyperglycemia because your pancreas is not really having an easy time making insulin. So you can have, again, glucose dysregulation. So another thing it has in common with liver, another thing for you to cluster with liver. Um, Here, fatty stools, that is something that else that you can have, that you might have with liver impairment as well, because if you're not having bile, you can have fatty stools. If you're not if you have lack of lipase, you're also going to have fatty stools. Yet another thing you can cluster with liver. And then look at this, jaundice, another thing that is usually liver related. Um, just because obstruction might lead to liver involvement. Because if this gets backed up, let's say the gallstone is right here, this gets backed up. Well, this is also getting backed up. And then this whole system is getting backed up. And the liver has another supply of blood that it gets directly from this GI system through the portal vein that can get backed up. So all interconnected. That's kind of just the key thing. It's all interconnected. Now, one of the biggest things I really want to stress is the complications. And you'll see kind of how this all kind of makes sense. So right here we have the major complications, and the main things here are the creation of fistulas. So a fistula is essentially like a connection that shouldn't be there. Why is this connection happening? The reason it's happening is because the pancreas is eating itself. So if the pancreas is eating itself, eventually it's eventually going to make like a hole and then cause fistulas to occur because it's penetrating through and then kind of working through that way. And some of the fistulas that are able to be created are between the pleural space, which is what the space that surrounds kind of like the lungs. They're not like the closest thing together, but like from this point on right here, the lungs are like right here, and they can be a little bit close to like where the pleural space is. And then remember, your lungs expand, so through that expansion, it gets kind of closer to the pancreas that way. So if you have the pancreas being broken through because it's digesting itself, you can have that creation of fistulas between the pancreas and the pleural space slash lungs, which now leads to fluid because your pancreas releases all these hormones and it's all kind of in like this fluid-like state, fluid getting into your pleural space, which is what's called as a pleural effusion. You have fluid in your pleural space. And that puts you at a risk for ARDS, which is acute respiratory distress syndrome. So this is a lung issue. Hence why in class he had you guys do like a question, like a little questionnaire thing, like his in-class questions, and his priority was not for the pain. It was not to be MPO. It was probably like the priority, or maybe well, the priority for him was like breathing. That's like one of your big complications is possibility of ARDS, issues with respiration, because you have pleural effusion because of the fistulas. The other fistula that can happen by the pancreas kind of digesting itself and having that um having those enzymes make all the way through the pancreas is with the stomach. And this one a little bit more obvious just because the stomach and the pancreas are very close to each other. As you can see right here in this picture right here. Pancreas, stomach right here, like it's right next to it. Is having a fistula between the pancreas and the stomach means you have the risk of having all this built up of stuff, bacteria stuff, kind of make its way into this system where it doesn't belong, and then you have risk of infection. So the main idea is that the ARDS and the peritonitis risk that are your main complications with acute pancreatitis, or like two of your main ones are caused by fistulas. And those fistulas are created because of the pancreas digesting itself and kind of breaking all the way through and then making a connection with something else. Does that make sense? Essentially, you have this little organ full of stuff. You poke a hole all the way through it, and then and now it's open and able to connect to other things next to it. Lungs expand. Now you have some of these enzymes probably picking at the lungs and creating like a little connection between the pancreas and the lungs. Now you're having fluid build up in the pleural space, and that's where you get your respiratory distress from. Little organ next to the stomach, same idea. Now you have infection. And then here, kind of going back to that necrotizing pancreatitis, we know that necro meaning death. Necrotizing kind of means like in the process of dying. So necrotizing pancreatitis is where it gets so bad, it's now the pancreas is having necrosis, so it's dying. It's having these fistulas and it's having like active infection. So this is like the worst possible thing that could happen. So let's see if we can get a picture. If not, it's okay. I don't know what I'm looking at there. Yeah, so here you see like this like darkened area where you have um, inflammation. This is probably where you're going to have it start to break down and start to kind of make its way through the pancreas and then start connecting to other things. Okay. And because of this, you have this risk of shock and infection because you have like an open injury, internalized bleeding. So that's again another situation with your internalized bleeding, your gray turners and colon sign. And again, the C for colons and then T because you have to turn them to see it. And again, this is something that can be seen through like abdominal girth. So if you don't physically see maybe see some of the internalized like bruising from the blood buildup, you might see like an increase in their girth, abdominal girth, which could be a sign of them bleeding. So now, um, let's see what else we got here. I guess I have a few more things for necrotizing pancreatitis. It's gonna be right here. So this is internal bleeding, like I mentioned. Some of the things you can expect with internal bleeding is ecchymosis, swelling, so increase in abdominal girth. Don't forget that. That could be a sign of internal bleeding. Keep that in mind. Changes in vital signs that we can agree kind of align with shock. And then back to infection again, because if it's making all the way through, we have that risk of peritonitis, and that can lead to sepsis, and sepsis can lead to DIC, sepsis can lead to ARDS. So again, it all kind of goes back to infection, respiratory distress syndrome. And then another thing that can happen is hypocalcemia. Um, and the reason for that is due to what he mentions is saponification, which is calcium soaping. So the lipase break. This is kind of all you really need to know is that the calcium go down. You don't really need to know the the logistics of it, but this is what happens: is the lipase, which is breaks down fat. Your pancreatic tissue is like a fatty tissue. So it breaks things down into fatty acids. Those fatty acids like to bind to calcium, um, and it essentially creates like soapy, like a little calcium soapy thing. And then because the calcium is being used up, that means you have less of it in your blood, and that's leads to hypocalcemia, which we talked about, I think, with leukemia. I think we talked about hyper, but I think someone brought up hypo, so I talked about hypocalcemia leading to tetany. So that's some of your like tetany is like your spasms and stuff, and you do have like two signs that go with it, which is right here. your Vostok sign, which is you can touch this part of the nerve and it makes them twitch. Trousseau sign is you put the blood pressure cuff on and then they become Italian and do the finger thing. Um, so those are your two signs. And then going back to the labs, um, we're just gonna kind of say serum amylase. You don't have to memorize the numbers, by the way, like at all. High. Serum lipase, high, because those are the enzymes that are leaking, and therefore those are the enzymes that are now high in the blood because they got to go somewhere. They're leaking, and now they're in the blood. So that's the explanation for that. Calcium, we just talked about, is going to be low because it's being used up by the saponification, which is saponification means the creation of soap. White blood cells is going to be increased due to inflammation and also potentially infection. CRP is an inflammatory marker that will be increased. Blood alcohol is something you can assess just because alcohol is a potential cause. Blood glucose will be high, like we mentioned, due to difficulty making insulin, like we mentioned prior. Your triglycerides, aka your fats, probably be high just because you're lacking some of the things used to break it down. So it's gonna, have a hard time kind of going down. Again, the liver and the pancreas work together pretty closely, so you'll have alterations in your liver labs. This inflammation, just like the liver, is something you can assess through ultrasound, CT. ERCP is due to gallstones. So if this is due to your gallstones obstructing, then this can lead to it can lead to you doing an ERCP in order to remove the stone that's causing it. So all of these things play a part in it. And your priorities. God damn, there's so much stuff here. Let's see how I can make this make the most sense right here. Oops. Boom. We're almost done though, actually. Surprisingly, we're making pretty decent time. ABCs again, like I mentioned, the lung fistulas leads to respiratory issues. So one more time, that is your ABCs. MPO to rest the bowels. Um, yeah, you're going to be MPO to rest the bowels. You're going to use the to reduce stress ulcers, proton pump inhibitor, H2 blocker, so protonics, famotidine, not for GERD, but for to reduce the risk of stress ulcers due to the gastric secretions. You're going to manage the pain. In general, with like GI stuff, having an NG tube to decompress the bowel, so having it to like low intermittent suction is good. Antibiotics to prevent like the what's it called, the translocation of bacteria. And then nutrition stuff because this person is not able to take in fluids or food because they should be MPO. Then they're going to need IV fluids. If they're MPO for too long, they'll need TPN, which you guys know all about now. And they'll probably have issues with their electrolytes, so they'll need electrolyte replacement, or at least the management of it. And remember, one of your calcium is going to be one of the things that is going to be decreased. So your calcium will be decreased. Your potassium will probably be on its way down because they're not getting any food. And then they can also get octreotide, just like the liver. So another connection, octreotide, because it can help slow down the secretions. Your assessment, again, is going to be your bleeding risk because of the necrotizing pancreatitis, respiratory issues because of the fistulas, and then sugar because it's your pancreas, and your pancreas deals with blood sugar. Jesus, there's so much stuff here. For complications, I will list some of these stuff. Some of the stuff again, we already kind of talked about. So malnutrition is a complication. When you're very malnourished, probably won't be the case with someone that's only malnourished for like a few days, but a decrease in albumin can also lead to third spacing. So yet another connection. Again, they're at risk of shock, of bleeding, and then just as a reminder, for if someone's at risk of shock or bleeding, they need two large bores. We need to cross and match their blood, prepare for the worst, and they might need packed red blood cells. They might need vasopressors, which you will learn more about. But you guys kind of have the general idea on what to do there. Acute kidney injury, because again, all of this is together. All of this kind of goes together. If they're not getting any fluids, AKI could happen as well. I mean, they're gonna get IV fluids, but you have to be really careful with kind of how much they're actually able to get. It's worth looking into. It's worth really assessing. Respiratory problems, diabetes, or slash difficulties with insulin, infection risk, hypoglycemia, just like we talked about. If there's any damage to the pancreas, risk of pancreatic cancer because scarring, causing damage means your body's like healing, and then whenever you're having an increased amount of healing, you're increasing the risk of cancer. Same reason why people that have a lot of esophageal strictures have an increased risk of esophageal cancer. That we talked about in 212, if you guys remember that somehow. Um, they're also going to have slower GI tract because again, this is all GI tract related. Something that they mentioned, which I'm guessing is probably going to be a fake answer choice or something like a incorrect answer choice is to not give Bentyl. Bentyl is a medication that slows down the GI. It's for people with like irritable bowel syndrome. So there's that. And what else? God, there's so much information. A lot of this though is stuff that I've been talking about. So MPO, hydration, bed rest, NG tube for suction, decompression, pain meds because they're going to come in for that. This is actually just kind of a summary, actually, now that I think about it. GI meds that we talked about, octreotide to slow down secretions. The positioning, I think it's just a decrease, I think it's to decrease the abdominal pressure, actually, the positioning. TPN if they need it. Antibiotics if they have infection due to this. Again, that assessment that we talked about. If they need surgery because the stuff above isn't working, then ERCP for gallstones, laparotomy to kind of assess and then see what they can do with it. If they have a pleural effusion, they need a thoracentesis. Now we have chronic. For the most part, you're going to see a lot of similar stuff. One of the main things that you'll see with chronic, it's mainly going to be caused from long-term use of alcohol. Acute is acute, meaning it's just starting now. This is like long-term damage. So uh, you'll have a lot more of the long-term effects. So it's called a boring, also known as a dull pain. So like a consistent dull pain. as opposed to like the very sharp pain that you'll have with acute pancreatitis. It's still a GI thing, so you'll have nausea, vomiting. It's still a GI thing, so you have nutrition issues. So these people have a risk of weight loss, diabetes. They can have clay-colored stools because they have a hard time breaking down fats. Or actually, no, that's a different reason. Actually, the clay-colored stools. Trying to remember actually the reasoning. I was thinking of fatty stools, which I think can happen too. Oh, the lack of bile is the reason for this. Yeah. So the lack of bile, if they have liver impairment, the bile comes from the gallbladder, but bile is made by the liver. So liver make bile, bile then goes down this track right here. So liver make bile, like up here, there's the liver. Liver make bile. Bile go down here, make it to the cystic duct, stored in the gallbladder. If it needs to be made, it will kind of come from here, maybe a little bit from here, make its way all the way down. The pancreas then releases enzymes, and they all make it to the small intestine. Yeah. So now labs, and this is very similar to cirrhosis, where in acute, you're going to have high LFTs. Here in acute, you're going to have high amylase and high lipase. But in chronic, you're going to have either normal or low because it's so damaged that it's struggling to even make the enzymes. Same reason for why your LFTs can be normal or low with severe cirrhosis, while with earlier liver disease, they'll be higher because the LFTs are not actually function tests. They're just enzymes that your liver can make. And then I didn't touch upon this on the liver side, but your ALT is more liver specific because it's an enzyme that's pretty much only made by your liver, while your AST can be made by other things. So having a high AST and a normal ALT could be a sign that it's actually not liver related, it might be something else. But that's um, further beyond. Okay. You can have pseudocysts and abscesses, but we don't really go over that too hard, so I wouldn't focus too much on it. The management to prevent flare-ups, these people are going to have to avoid alcohol and caffeine. They're going to have to modify their diet. So the way to do that is they're going to need to take enzymes. They're going to need to take some of these enzymes in order, before eating, in order to be able to digest properly. Something that is good to know is that they want to avoid mixing these enzymes with dairy because it can cause the enzymes to start taking effect earlier than it should, and it could either be wasted or it could just cause damage to the mouth because these enzymes are going crazy and causing damage. As per always, small frequent meals is always the answer. Low fat, moderate carbs, high protein. I think for the most part, like a lot of the things that really struggle to break down is the fats. So that's kind of the reason why. But they still need to eat, so they can't just not have um their calories from, because these are the three main groups, so you have to have your calories from something. So that is done through high protein, moderate carbs. High protein keeps them full, better, so they don't have to, um, just have a lot of the issues. They might have to take insulin and stuff. Just like we mentioned, the pancreas can struggle to make insulin. Any questions so far? Because I know we just did a lot, and I know we're going super fast. So if you still need more help, again, the videos from last rotation are still there where I definitely go slower. I do go slower, and I technically cover more stuff, but here again is just the most important stuff here. So there's probably going to be more fluff on the other one as well. If there's any questions, just feel free to type it. Now there's pancreatic cancer. I have it already written out for the purpose of that pancreatic cancer is really not tested hard heavily on at all. So you really don't need to know too much about it. The main thing you really need to know about it maybe is that there's a CEA, which is a cancer marker. That could be something that shows up elevated. For the most part here, most of these signs and symptoms are things you already learned from general pancreas issues and even some liver issues. Maybe the only specific pancreatic cancer thing to know is the blood clots. I guess some of those tumors have the properties to release more clotting factors and cause you to have more blood clots. But again, this topic is not heavily tested on. You do have your management. Pretty much when in doubt, your cancer management includes radiation, chemo, and surgery, and they don't go into heavy detail on how it's done. Really don't have to worry about knowing any of that. He does very lightly talk about Whipple surgery. I do have a picture just so you can see how crazy it is. They completely rearrange your insides. Pretty crazily, actually, if you look at it. Um, Probably the only thing I would really worry myself about with this is knowing some of the post-op. So you just had massive kind of like GI tract surgery. So you're going to be MPO. You're going to have an NGT to low intermittent suction to decompress. Because you're MPO, you have, and this is such a major surgery that you're going to want a central line because you're probably going to want multiple different things on you. You're probably going to want a high amount of fluids, medications, maybe a blood transfusion. You can have different tubes because this is a major surgery, so you can have various things that like T tubes that's there to drain excess bile so that it's not getting stuck and causing issues. Basically, there's a lot of stuff going on with this, but they don't really test heavily on the Whipple either. For the most part, it's going to be stuff that's very intuitive if you do have like one question on it. And the complications are a lot of the same stuff. One of the complications is it doesn't work, and you have a lot of the same signs and symptoms that comes from these pancreatic conditions to begin with. When in doubt, I also have links to Nursera and stuff if you feel like you need extra information. But again, I do think the summary that you have here does cover a lot. And again, this midterm is going to have a lot of topics, so it's not really going to be in heavy, insane detail. So just keep that in mind. Any questions on pancreas? We'll give you guys this. And I will again repost the links to the video. So if you feel like you still need a little bit more, you can go ahead and watch those. So here is this outline, and I will link the videos again. Okay. Any questions? Any other thoughts and concerns about kind of what we did? I'll just end the recording now.